we're not enrolling in. So we are going to talk today a little about some of just the basics of the things that we, especially as APPs, see. You know, there's a lot that goes on with clinical trials, and a lot of it is stuff that's behind the scenes that's happening with regulatory and IRB and such. But that stuff doesn't usually include us until patients get to clinic and they need enrolled in trials, which then includes its own, you know, caveats of things. So some of you are going to be pretty familiar with this because you've been here at the mothership for a while and you've probably put many patients on trials over the years. And some of you this might not be quite as familiar with. So we'll get into it. Next slide. So there's different kinds of research studies. There's observational and there's interventional. So observational things are like case reports, which, you know, some of us have been a part of. A patient comes in with sort of an interesting presentation or has multiple malignancies at once, and we write that up. So those are descriptive studies. There's analytical studies that are like cohorts or case controls. There's also the interventional studies, which are, you know, a lot of the ones that we run that have randomized controlled trials. There's non-randomized controlled trials. There's ones that are interventionals. There's ones that are just for quality of life. Some of them are diagnostic. Some of them are prevention trials, like vaccine trials and things like that. So there's many different kinds. You know, a lot of us probably think research, clinical trials, we're giving this versus this, and that's not always the case. Next. So this is how drugs are developed. You know, we see part of this here, and then there's a lot of it that we don't see. So we go from the preclinical development where things are happening in a lab. Somebody who's much smarter than me comes up with this idea. They take it to the lab, they test it on mice, usually, and then it eventually makes it into clinical trials. Now, granted, not all things that get tested in the lab ever make it to clinical trials. There's a whole lot of things that have to happen through the FDA, and there's many millions of dollars that have to be poured into that for someone to even pick it up and put it through a phase 1 clinical trial. So once you get to the clinical trial portion, there's phase 1, 2, 3, and then eventually 4. Phase 1 trials are usually, we'll go through these a little in a minute, but phase 1 are usually the first in human trials, and there's, you know, 5 patients in the country or 10 patients on the whole world that are put on phase 1 trials. If things look good, we move to phase 2, where then there's, you know, 30 to 100 patients or something like that. Then we can move on to phase 3, compare it to the standard of care, and there are thousands of patients that go on that clinical trial. At some point during that, the drug could be FDA approved. We approve a lot of oncology drugs based on phase 2 trials, but eventually the FDA approves it, and then we move on to phase 4, which is the post-marketing phase. Next. So like I said, phase 1 is the first in human trials. So a drug got tried in the lab, got tried on the mice, looked pretty good. Now let's see how humans respond to it. These are open label. These are non-randomized. They are called dose escalation trials, and they are uncontrolled. The primary endpoint is actually not to see if the drug specifically works. The drug is to find out what the dose is going to be and what the rate limiting toxicities are. We also are looking for what side effects they have. A secondary endpoint is, do patients respond to it? So a lot of these clinical trials look at, again, they're dose escalation trials. So a patient gets 10 milligrams, then the next time maybe they get 20 milligrams, then they get 30 milligrams. We're figuring out what the maximum tolerated dose of the drug here is. These clinical trials are extremely involved because we're giving a patient a drug that we might not know all that much about in terms of their side effects, right? So we're saying to a patient, this is what it looks like, this is what it's potentially going to do, these are the potential side effects, but this is where we really find all of that information out. And this is something, you know, there's only maybe 10 patients in the entire world that go on these clinical trials. There's maybe only 3 in the United States that go on these trials. So these spots are also very limited. You'll see that this is looking at the pharmacokinetics and pharmacodynamics of the drugs in humans. So what the drug does to the body and what the body does to the drug. You might see in some of these protocols that they say we have to draw PKs at certain points after we give the drugs. That's the pharmacokinetics. That's the absorption, the metabolism, the distribution, the excretion. That's what we're looking at when we give a patient a drug here physically at the cancer center, and then say at 1 hour, at 2 hours, at 4 hours, at 8 hours, you have to have labs drawn again because we're finding out what is happening in the body. Next. So then we move on to phase 2. If the phase 1 data is promising enough and we find out that we can have patients tolerate that drug and that maybe that drug is starting to show some early response rates, we move on to phase 2. This has probably up to 100 people in it throughout the country or throughout the world if it's an international trial. This one might actually include placebos. Unlike phase 1s, phase 2s can have placebos. Typically, we figured out what the maximum tolerated dose is, and patients get that same dose, although some phase 2 trials will take a look at different dosing schedules or potentially even different doses of the drugs, but that's not usually the case. I will present a patient case later that actually looks at different dosing schedules. Next. So then we move on to phase 3, and we call these confirmatory studies. So this one has usually thousands of patients enrolled, and there's different kinds of ways that we do this. These can be placebo-controlled if they want. A lot of these are double-blinded trials, although sometimes that's not always possible. Double-blinded meaning the patient doesn't know what they're getting and we don't know what they're getting. Eventually, some trials are unblinded, but that's usually about 20 years down the road. So typically what happens with a phase 3 trial is patients get randomized to one arm of at least 2 arms. Usually there's many. And typically one of those arms is the standard of care. In the phase 3 trials, we're trying to determine if whatever this new thing is better than the current standard of care, which again, we'll talk about later when I present my case. Next. This is just kind of a schema that I found. So you screen somebody, and then we talk about getting them enrolled and eventually randomized into trial. Next. So like we talked about earlier, we do phase 1, 2, and 3. At some point after phase 2 or 3, the drug might get FDA approved. And then once it has FDA approval and it's gone through phase 3, we move into phase 4, which is a post-marketing surveillance. These are uncontrolled, they're just observational, and we follow patients for a long time on trial, right? Especially if you're like a breast cancer patient. These patients live a very long time. It takes us a long time to get an overall survival data. Sometimes it takes us a long time to get a progression-free survival, but we follow these people for a long time and determine, do they have long-term side effects, or are there some sort of rare side effects even after the drug has been FDA approved? Next. So in terms of what we do for clinical trials, right, there's lots of room for APPs in trials, but one of the main things that we're doing is seeing patients, screening them for trials, getting them enrolled, and then following through. Clinical trials are very particular about everything they do. If you've seen the clinical trial protocol, there's a binder that the clinical trial nurses bring with them that's real thick. It's got hundreds of pages in it of everything you can think of related to that trial. And they're very specific on what they want. When you say a patient signs consent, then you have X amount of time to get that patient started on drug. And then if they need to be seen every week, it tells you you have plus or minus 1 day to actually see that patient in that week. Every little thing is spelled out. We have to be very careful on documentation with clinical trial. And it'll spell out, again, exactly what it wants in terms of, for your physical exam, make sure you checked the lymph nodes and the sizes. I documented for one the other day that said it wanted to know about peripheral pulses, and it specifically wanted radial and brachial and like popliteal pulses for whatever reason. So I had to make sure that I checked those and documented. I would probably never check a brachial pulse on a patient. The other thing that you have to be very careful documenting is what side effects they have from treatment or what things they came into this trial with, right? If they've got a baseline neuropathy, you need to know that. But they're also specific on the grading system. So we use something called the CTCAE grading system, for which there's an app. If you don't have it, you can download it. It is free. And it tells you everything in there, right? So if a patient has diarrhea, you can type in the word diarrhea, and then it walks you through grade 1, 2, 3, 4, and then, well, grade 5 is usually death. But it walks you through all of those to tell you however many times they have diarrhea and whatever intervention you had to do, how to grade that, because that all has to be documented on trials. Missteps whenever you are documenting things or whenever you're doing things. If you just sort of decide to do what you want to do and not what the trial says, those result in deviations, which is a lot of paperwork, but also it doesn't necessarily look great on us as providers or as an institution that you're not following the clinical trial, because there's a reason that we do things the way that we do with trials. When in doubt, check the protocol. That protocol is your best friend when you put a patient on trial because it has everything spelled out in it. There have been a couple of times where I'm not exactly sure what the trial wants or what the protocol says because it can be a little vague, in which case you can contact the sponsor and they can guide you on whatever they want, because their name, phone number, and email address is in there, and they're usually very responsive. Next. Okay, so let's go through a patient case. This is a guy I actually put on trial not that long ago, and it's been an interesting one because I haven't put anyone on this trial before. So this is a 62-year-old male who was diagnosed with CLL in 2018. He had a bone marrow biopsy completed at the time that showed that CLL was comprising about 10 to 20% of his overall cellularity in his marrow. He didn't meet any of the criteria at the time for CLL. We do follow these patients sometimes for a long time. His white count was actually very slightly elevated. His lymphocytes were very slightly elevated. He didn't have, at the time, he didn't have bulky adenopathy. His doubling time wasn't significant. He didn't have any constitutional B symptoms, so he didn't actually meet any of the criteria. Next. So over the years since 2018, we've just been following him, and he's starting to have like a little bit of abdominal pain. And now he is starting to have, he's popping up with these lymph nodes that you can kind of see on the exam. You don't even have to feel any longer. So we got a PET CT scan recently, which showed he has bulky adenopathy, bilateral cervical supraclav, axillary inguinal, and a whole bunch of retroperitoneal adenopathy. So he now qualifies for treatment. He still doesn't have any constitutional B symptoms, and his white count and lymphocytes are actually fairly stable. They went up a little bit, but it wasn't significant either. But when we talked to him about different kinds of treatments. So for the standard of care for CLL, right, we offer patients either single agent BTK inhibitors like ibrutinib or acalabrutinib or zanubrutinib, or we offer them venetoclax and obinutuzumab, which is a fixed duration, versus the BTK inhibitors, which are lifelong, right? You take these until progression or you can't tolerate them anymore. But the venetoclax obinutuzumab upfront is just 1 year. Or we talked to him about this clinical trial. So the name of the trial there is the M24-287. It's a study to evaluate the risk of tumor lysis syndrome in adult patients receiving oral venetoclax in combination with IV obinutuzumab or oral acalabrutinib for previously treated CLL. Next. So this clinical trial is a phase 2B/3. It is a randomized trial, and there are 4 arms. So the first arm, arm A, is obinutuzumab with venetoclax and a 5-week venetoclax ramp up, which is exactly what he would get off trial. That is one of the standard of care. The other standard of care being single agent acalabrutinib or another BTK inhibitor. So then arm B, C, and D are all acalabrutinib with venetoclax, depending on the venetoclax ramp up, right? So the arm B is a 5-week, arm C is a 6-week, arm D is a 7-week. The primary endpoint here is to determine the percentage of patients who have tumor lysis syndrome and hyperkalemia. Note that the primary endpoint is acalabrutinib and ven better than ven-abin. The secondary endpoint is the percentage of patients with reduction of tumor from their baseline, but also the percentage of patients with adverse events from tumor lysis syndrome. Next. The inclusion and exclusion criteria are listed there. You know, essentially with clinical trials, we want patients, especially this clinical trial, this patient hasn't been treated before. It's what they're looking for. They're looking for people who have, you know, adequate marrow function, who have adequate kidney functioning, and who are of a good performance status. The exclusion criteria are you can't have people who have thrombocytopenia, who have an active or uncontrolled infection, or what we call Richter's transformation, which is where the CLL has then transformed into a diffuse large B-cell lymphoma. So after talking to this patient extensively about all of this, he decided he was going to go with the clinical trial because he definitely wanted something that was fixed duration. And this clinical trial is also fixed duration, even though it has acalabrutinib, which off of clinical trial would normally just be until progression, and might be years and years down the road. He decided he wanted something that's just going to last about a year. So he did sign the consent and is excited about getting randomized. Next. So prior to being randomized, there is a list of screening stuff that he needs. He needs a CT or an MRI. He needs a chest x-ray if it's clinically indicated, which in his case it wasn't. He needs an ECG, he needs an echo, and he needs a whole bunch of lab work. We had just done a PET CT on this patient, and that normally could have been used. However, it was done at one of our regional sites, and the trial for some reason will not let something that was done at a regional site be included. So then we had to go back and repeat his scan here, even though he already had one. They also wanted documentation of the detailed physical exam, something called the Binet staging, which is not the way we actually stage CLL here in the United States. We use Rye staging. The Binet staging is a French staging, and I'd never used it. I had to Google it and find out what it was. The documentation of whether or not he has B symptoms and any other symptoms that he has at baseline, because things at baseline are then not going to be included, right? He has grade 1 peripheral neuropathy and he has grade 1 intermittent abdominal pain. I don't know if those are going to go away. I don't know if that abdominal pain is actually a result of all of the retroperitoneal adenopathy that he has. We'll find out. But it's important to know what he has that's not necessarily going to be a side effect from the drugs. From the day he gets randomized, he has 28 days to start the drug. So after all of these things are completed, they get sent into the trial company. Then the trial company randomizes him. He has 28 days to start. Next. He did get randomized after I made this presentation. So we did just randomize him. He got randomized to arm D. So he is going to get acalabrutinib for 3 cycles. So that is actually 3 months. And then you start on the venetoclax ramp up. But his venetoclax ramp up is going to be 7 weeks, unlike the normal 5 weeks. So he's going to get 10 milligrams the first week, 10 milligrams the second week, then the 20, 50, 100, 200, and then 400 beyond that. When he gets his venetoclax ramp up, and this is with any of the venetoclax arms, they get labs at baseline and then have PKs at 1, 2, 4, 6, 8, and 24 hours so that we can see what's going on in the body then. This is a fixed duration of 15 months, but they do get followed for 28 months. And again, what they're mainly looking for is does he have tumor lysis and what side effects from tumor lysis does he have? Next. Okay. So he's going to be followed pretty closely, and we're going to be worried about documentation the whole time of asking a million side effects. You know, are you taking your drug? He actually has a little diary that he has to put every time he takes his drug on there, what day and time and all of that good stuff. So then he brings that back. We dispense him more drug every time he's in here. And then at the end of 15 months, he will just simply be followed, but the clinical trial will still be determining what lab work he needs and when he needs to be seen. So even after drug is sort of discontinued, we are still doing, you know, what needs to be done for follow-up. Does anybody have any questions about things? No? Perfect.
You just did a perfect job. So it's also your time if you've done any, if you've been involved in any clinical trials and you have a question about that, you can also ask what these are for. Perfect job. No notes.
Everybody's ready to go back out in the rain.
Okay, well, if nobody has any questions, we'll just thank Sam for her time and everybody have a really nice Memorial Day weekend.